Good morning, everybody, and again, a warm welcome. Lots of bustle in the audience, which is fabulous on such a warm and sort of Indian summer's day almost really here. But first of all, welcome to the evolving role of the assistant practitioner, the future of progress. So it's a conference about yourselves, about the role of the assistant practitioner, and we really want you to get the absolute maximum from today. My name is Paul Sewell. I'm a practice education facilitator with the Norfolk and Suffolk Workforce Partnership, and I'm actually hosting the day today, along with our chair, Cathy Branson. So, as I say, a very warm welcome. We've got a full audience here today. As you may see, we're actually using a number of different venues, and we're actually been using the Eton Suite, as well as the Sunningdale Suite that you see just here. So this will be our main venue for the day. We'll also be using, as I say, the Eton Suite, which is actually downstairs, just down the stairs, and then immediately to your right. That's one of the breakout sessions for this afternoon, which I'll come to in a moment or two. And we'll also be using the marquee. Did everybody make it down to the marquee this morning? Yep. Fabulous. Decent toffees, decent teas? Jolly good. So to actually access that, you can actually access straight down the stairs just here, probably the way that you just came up just now, and that'll be for the breaks really. So firstly, I just want to remind a couple of sort of basic sort of fire safety bits and pieces at these events we need to cover. So there's no expected fire alarms today, so hopefully we shouldn't hear any noises. If we do hear any alarms, and the emergency exits we just actually have just to our right, or we actually have just behind you, and my colleague Sue is just there, so just look behind. But as one person said to me many years ago, if there is a fire, follow me, because I'll be first out of the door. So, but a few other issues just to mention. We are actually filming today's event at various points, and there is a photographer in the room as well. If you do have any objections to any photographs, please do come and let me know, and we'll make that provision for you. But again, as I say, welcome to the day. I'm just going to take a few moments just to actually go through the programme a little bit, just to give you a little bit of an overview of how the day will pan out for you. So at the moment it's myself. I'm actually doing the welcome and housekeeping bits and pieces. We'll then be following with session 2, which will be looking at the strategic view of the assistant practitioners and health and social care, and that's actually being presented by Cathy Branson, the Director of Norfolk and Suffolk Workforce Partnership. That will be alongside Lorraine and Barrett, Head of Social Care, East Norfolk County Council. We'll then actually be breaking for teas and coffees, and that will actually be with the exhibition stands in the marquee, just back where we actually were. We then, after our tea break, will actually welcome you actually back up to the sessions here. We'll be actually having a range of sessions with colleagues from University of Suffolk, and that's Paul and Julie will be coming up to talk from that point of view, and Julie White, one of my colleagues from the Norfolk and Suffolk Workforce Partnership, will be offering her session. Lunch, we will actually be taking downstairs, looking at recovery lunch downstairs. The key thing is actually this afternoon's session will actually be breaking into 2 groups. Assistant practitioners and training assistant practitioners will be actually meeting up here in the Sunningdale Suite. And managers will actually be meeting in the Eton Suite, which, as I mentioned, is actually just downstairs, just at the bottom of the stairs on the right, but we can signpost that to you a little bit later. After those 2 sessions, we'll be welcoming you back here for our final session, which will be hosted by Cathy Branson and Harold Bodmer. So, let's say, just to recap, as I said, we've got the main conference rooms, our marquee and exhibition areas, the eating room, and the dining room for lunch. Your feedback for the day is really important. We really would welcome your feedback. And have you got various tokens been given to you this morning? Okay, so what we actually asked you to do, there is actually some feedback we'd actually like to do. We'll fill in a little bit more detail at the back, but we actually have got a feedback wall at the back of the venue. Would ask you actually, if you've actually got your phones, if you would put them onto silent, if you would be, so kindly, much appreciated. We also actually have a tweet set up, so if you have got feedback, we'd really welcome it. It's a #KSPRAC. So we'd welcome your comments, feedback on the event. We'll try and feed those back during the actual session. But really, really importantly, there's been many, many people in the setup for today to putting the whole thing together. I'd like to thank them for all their actual input and for making today's session actually happen. And that goes to those that have been filmed, those who've actually created the event, and you yourself for actually attending. So, just to give you that warm welcome to today's event. So, I'd like to now hand over to Kathy Branson, the Director of the Norfolk and Suffolk Workforce Partnership, to introduce the evolving role of the Assistant Practitioner, the strategic viewpoint. Welcome, Kathy.
Oh, you picked my notes. You can't get the staff nowadays, I don't know. Good morning, everybody. Good morning. Thank you. This is really great, isn't it? I mean, if you think about it, this room full of people talking about assistant practitioners, I'm really excited about this. I'll probably explain during the course of my presentation why I'm so excited, but for me, the role of the assistant practitioner is absolutely the future. It's a patient-facing role, it delivers essential care to high quality, and it can work across patient pathways. And actually one thing we know about the NHS is we can't keep doing things the same way we've done them before, because we're going to run into, well, we have already run into big problems. So for me, the reason this is about the future in progress is because for me the role of the assistant practitioner is absolutely key to that. I'm going to tell you a little bit about health education east of England, not because I want to make you fall asleep, but because I think it's important to put a bit of context on why we're here today. I work for Health Education East of England, which is the regional system that funds education and training, that funds workforce planning and workforce strategy, that funds leadership and also workforce transformation. And for those of you in the audience who are assistant practitioners, those of you who are managers of assistant practitioners, you can see that actually Health Education East of England has a key role in making sure that we drive this process forward. You'll have to excuse me, I've managed to come down with a cold for some reason because the sun's shining, so if I cough, that's why. Health Education East of England is divided into 4 workforce partnerships, one in Norfolk and Suffolk, one in Cambridge and Peterborough, one in Essex and one in Bedfordshire and Hertfordshire. And Norfolk and Suffolk is actually leading the way on assistant practitioners. We've done a tremendous amount of work, and some of the work that we're doing is now being taken and rolled out regionally, but it's also being taken and rolled out nationally. And part of my job is to make sure that some of the lessons that we're learning here today are taken to the national platform so that other assistant practitioners across the country can learn from the things that we've done. So this is a really important session for a number of reasons. The governance structure for the Workforce Partnership is that we have an executive group that involves every chief executive from every provider organisation. By that I mean trusts, independent organisations such as SACO in Suffolk. So all of the chief executives from those organisations, plus all of the chief officers from the CCGs, the clinical commissioning groups, plus all of the directors of adult and children's social care. So, and also some other people like the Pro-Vice Chancellors from the universities. So what we do is every 3 months is get all of the leaders in the Norfolk and Suffolk system together to talk about how we need to change the workforce in order to deliver the things that we need to do in Norfolk and Suffolk to make sure that we meet the needs of our patients. And they've come up with 5 priorities, which I thought were important because actually the role of the assistant practitioner can contribute to the challenge that we've set ourselves and actually delivering these priorities. So the first one is about improving care for frail older people with a particular focus upon people with dementia through education and workforce transformation. We all know, don't we, that Norfolk and Suffolk, first of all, our population is growing, but our older population is growing exponentially, and we expect to have 122% increase in the next few years of people over the age of 85. So we've got what's known as a demographic time bomb. Sounds horrible, but actually what we've got is a challenge because the majority of our patients, whatever setting you're in, are people who are older people with a set of complex comorbidities. The next one is we want to brand Norfolk and Suffolk as the place to work. We want Norfolk and Suffolk to be seen as the place where we deliver the best care, where we have the best people, where we provide the best leadership opportunities, and also where we have innovative approaches to developing and transforming the workforce, and you're a big part of that. We want to develop a flexible workforce that can work in a range of settings to deliver person-centred care. If you think about people who are older people with complex comorbidities, they often receive care from health services, from social services, from a range of other non-statutory community services. And the role of the assistant practitioner gives the freedom to develop a role which is focused on what the patient needs. And when Lorraine comes on, she's going to be talking about that role in an integrated care setting and the benefits of the assistant practitioner role. The next one's really important. We need to shift the culture of care delivery in Norfolk and Suffolk. And by this I mean, we need to respond to the Francis report. We need to recognise that the NHS has had a series of crises where patient care has not been exemplary. But we need to recognise that senior managers such as myself have a responsibility to understand their contribution to the culture in which practitioners such as yourself work. Because I know in the NHS we're great at measuring things and ticking boxes, but we're not actually always great at supporting our staff, listening to our staff and making sure that they have the capacity to do the job that they were trained to do. So it's really important that the chief executives in Norfolk and Suffolk have recognised they have to work together to address this issue, because you, our staff, are our most valuable asset. The final one isn't a priority in that we're going to deliver work against it, but it's an underpinning principle, which is we are going to have a shared vision between providers and commissioners. We're going to start being honest with each other that we're not doing very well, that we don't address urgent care issues, that winter pressures keep us on our knees until July every year, that we actually haven't reduced acute activity. So let's start talking about the elephant in the room, because pretending that it doesn't happen hasn't got us anywhere. So we're trying to make sure that we're much more honest and much more bold and ambitious in order to improve services in Norfolk and Suffolk. So what is an assistant practitioner? I think for me the biggest value of an assistant practitioner role is the ability to be flexible across a number of roles and across a number of professional groups. So it's somebody with a set of core competencies, but it's somebody with also multiple role-specific competencies, which means for the first time we can design a workforce based on patient needs rather than the needs of the various professional groups, which I think is a plus. It's about recognising that they have skills in addition to the skills of traditional healthcare support workers and are able to undertake a range of tasks and be accountable for those. I've just got a couple of quotes. So Skills for Health said it's somebody with a level of knowledge and skill beyond that of a traditional healthcare assistant or support worker. And NHS Employers said it's a non-occupation specific role that has been developed to assist organisations in delivering services in a variety of settings. Two quotes, but actually the most important thing is it's a skilled practitioner, first of all, and it's about recognise the level of skills that assistant practitioners have and allowing them to work to that level of skills, but also it's a flexible practitioner who can develop a role across a range of settings. I think we've done a lot of work, and there's a lot of evidence of the kinds of things that assistant practitioners can do in practice. There's a lot of evidence about what's a good supervisory framework and what's good governance around assistant practitioners. I would suggest that we're still a little bit hesitant in understanding the benefits of the role across the piece, and I think we need to do some more work on that so that we're absolutely confident that we have a capable workforce here, because I believe we do. There's a national focus on assistant practitioners at the moment. Excuse me. There's been a number of reports recently. I mean, I don't know if anybody saw the Cavendish review. It was an easy read, actually. Well, it was a horrible read in one sense, but it was an easy read in that it was written by a journalist. And it said a range of things about how we train our staff in the bands 1 to 4. So staff who don't go through a registration process. And there was some quite horrendous evidence there of nursing assistants who were given a video to watch overnight and then come on the ward the next day and deliver patient-facing care. There's a number of scare stories out there about people who have not been prepared to undertake the roles that they need to undertake. My view is that the evidence is that you guys deliver probably about 60% of patient-facing care. So it's really important to make sure that you have the right training, you have the right support, and the right opportunities to study, and more importantly, that you have equity with other registered groups, because at the moment, for me, the balance seems a little bit unequal, and we need to address that really importantly for a whole number of reasons. I suppose the first reason is because widening participation is really important. We need a good mix of people in the health service. We need to encourage local people into the health service, people who've got a stake in delivery of local health care. And also there's a lot of good evidence that people who come up through the assistant practitioner route are grounded in the values of the NHS. So it's about making sure that we celebrate the importance of the role. The Francis report, I don't really know what to say. I mean, the Francis report said terrible things about any number of ranges of groups, and then it didn't say anything about some other groups. So I was talking to an allied health professional colleague the other day who said they were really quite pleased that it didn't say anything about allied health professionals. And I said, that's interesting, because wouldn't they have been on the wards? Wouldn't they have seen the care that was being delivered? So the fact that they said nothing is not actually to your credit. You know, we are all culpable, in fact, for what happened there, and we are all personally responsible to make sure that it doesn't happen on our watch. And my view is the role of the assistant practitioner is vital in delivering high quality essential care, but more importantly, it's vital in helping us blow the whistle when things go wrong and to take action to make sure that it doesn't happen in Norfolk and Suffolk. We've got minimum standards for healthcare assistant training, and Cavendish actually will be saying that all people who work in clinical support roles will have to have a minimum level of training. I'm not sure if you are aware, but a little while ago the Secretary of State woke up one morning and thought, I'm having a bright idea, and said that all nurses will have a year as a nursing assistant before they go into training. For my sins, I'm leading on that work in Norfolk and Suffolk. And it was a very odd idea, I will say that. But actually, we're actually drawing quite a lot of learning out of it. What we're drawing out of it is, what's the best way to recruit our support staff? Do we make sure, how do we make sure that people are recruited for both values and also things like numeracy and literacy? How do we make sure that our staff get a common training programme, and how do we make sure that that's certificated? So if you do a training programme in one organisation and you move organisations, you don't have to start right at the bottom and get retrained, but actually everybody recognises that these skills are transferable. So from a very odd notion, actually Norfolk and Suffolk has delivered something that looks really exciting, and we're drawing quite a lot of learning out of that, which will help us think about assistant practitioner roles also in the future. So why is there a focus on assistant practitioners in Norfolk and Suffolk? I think the first thing is because it's the right thing to do, because it's a flexible role, it's an important role, and that's what we need. But we also have some sort of demographic issues. We have an ageing workforce, which means that we're running into a big blip of clinical staff who will retire in the next few years. So we're running out of staff. And actually, interestingly, we're not putting new people from Norfolk and Suffolk into the pipeline. And the reason is because in Norfolk and Suffolk, historically, generally this is, we have low academic attainment, and both of our universities expect people to have significant A-levels in order to enter onto nursing degree programmes. So we're actually training quite a lot of people from outside of the patch. It differs from university to university, but we do have a problem with unemployed young people and also a skills gap in the NHS, in that we're not getting young people into the system. So actually a grow your own route for people who don't follow the straightforward academic pathway is absolutely something we need to look at. We have an ageing population, as I said. Norfolk is the oldest county, probably in England. There's something about perception, there's something about integrated care which is now being talked about at government as the only way that we can bail out the health and social care sector. I believe that's the right thing to do. And of course the assistant practitioner has the potential as a role working across health and social care. Talked about working in Norfolk and Suffolk. We want to grow our own people, but we want to make sure this is a great place to work where we deliver the best care. There's a number of workforce challenges. As I said, the national focus is about increasing the quality of care through education and training. Sue at the back there did an audit of assistant practitioners, and one of the things that it showed us, actually sadly it was no surprise, but it showed us that not all of our assistant practitioners get the same opportunity for study support, for mental support in the learning environment as our registered staff do, or our students who will become registered staff, and that's simply not okay. If we value patient care, then we have to put the resources into the people that are doing the job. There's going to be fewer nurses, and we've got the graduate entry issue which I talked about. And there's also something about, we are under financial pressure all the time, but there's something about productivity. It's something about designing a workforce that's fit for purpose, as well as a workforce that costs less. I think actually cost is something that should be a byproduct, or saving should be a byproduct of doing the right thing rather than drive the right thing. I've got a film clip now. I'm not sure what I do. Do I just stand here and someone puts it on? Yeah.
The history of the assistant practitioners goes all the way back to 1998, when we were planning this lovely new hospital. And we wanted to actually look at the roles we needed and the activities we needed for people to look after patients within this hospital. So we undertook a very big activity analysis within the old Norfolk and Norwich, and that was in nursing, physiotherapy, occupational therapy, in all areas. And what that showed was that we'd got people who were registered nurses undertaking roles that really they didn't need to do as registered nurses, but also nurse and auxiliaries undertaking roles that they weren't qualified to do. So, and it also showed that we needed a role whereby people could not only do nursing skills if you're in a ward, but some physiotherapy skills and some occupational therapy skills and a little bit of dietetics. And in OT, occupational therapy and physiotherapy, they have different needs, which I will talk about. So from that beginnings, we actually started to develop the role. And the other area we wanted to do was this just about acute nursing, or was it also about nursing and occupational therapy and physiotherapy as a whole? And so I talked to my colleague, Kathy Branson, who was Director of Nursing in the Community, and Kathy said, no, we need that too within the community. So it actually became an acute and community initiative, and that's how the role actually developed.
I was very lucky in being asked to join the assistant practitioners course. It was a course that nobody really knew anything about. It was being developed. As Carol has said, there was resistance from the RCN. It was considered that if we did this role, we would be taking over what was then considered to be the old SEN role. But we weren't actually filling that role. This was a new role. It was a progressive role, and I think that had been overlooked at the time. They hadn't really looked as to what the role was and to how it could develop within the trust. And we actually fulfilled a big gap in that role as an assistant practitioner, and we began to become, how can I put it, we were accepted and we were responsible in that role, and we were looked upon as being, yes, they can do it. Whereas beforehand, that was, well, there's nobody to do it, we'll have to wait for one of the staff now.
We were involved quite early on in terms of the development of what has become the assistant practitioner role. It was the old BTEC role, and I was always very aware that in my younger days, many years ago, I actually learned quite a lot from the assistant practitioner equivalents that we had then, but there was no career structure in any of the therapies. People were abandoning, they were unqualified workers, and that's the only place they could go. And being qualified isn't for everybody, but there was no progression, there was no way of them developing their learning and sharing those skills. But beyond that, we had people who'd been working as assistants and thought, we challenged them really in terms of going forward for doing this, because they didn't ever think they could do something like this. And it was a qualification, and it was very important that it was working across different areas.
We introduced the assistant practitioner role through the development of integrated teams, and initially how things were organised. We used to work in a very uni-professional kind of way, so we had assistant staff who worked primarily with nursing staff or with therapy staff, whereas with the introduction of a more integrated way of working, we needed a role that would support that. So the assistant practitioner role is primarily aligned to either nursing or therapy, but they have core competencies in other areas to enable them to provide holistic care.
Within our team, the AP role consists of an AP who takes frontline calls and referrals and undertakes a triage of that work and establishes how best to proceed with that. If they feel ongoing support is needed, they'll undertake an assessment, and they will liaise with a qualified member of staff in the team to gather advice if they're unsure of how to proceed with the case, if there's safeguarding concerns, if there are issues around complexity, someone has cognitive impairment, anything like that, and they'll seek advice and they'll undertake the work to the best of their ability. The role of the AP was introduced to act as a support in terms of taking on the work and providing a good level of service and a good quality of service to enable the qualified staff, the social workers, occupational therapists, to deal with the complex cases, and then the AP would deal with the cases which were perceived to be less complex.
West Suffolk started to think about the introduction of AP roles in the middle of 2010, and we had our first cohort who started their foundation degree programme in September. The reasons that we introduced the AP roles were primarily around the difficulties in recruitment to Band 5 registered nurse posts within the trust, and I think that was similar to many other surrounding trusts throughout, and also throughout the country, I think. But also it was a little bit about looking at where the skills and abilities of the team that we had at present, and looking at how we could more effectively deliver care. And the assistant practitioner was a new role which bridged the gap between the nursing assistants and the registered nurses. The AP roles sit within the ward teams. They very much are team leaders for the basics of care and the nursing assistants. So they're very much advocates of good practice and the fundamentals of care. But they also support the registered nurses in undertaking many of the clinical activities that the registered nurses used to undertake. So they will do complex dressings, for example, wound care, and they have a very solid theoretical background underpinning their skills and activities on the ward.
As an organisation, we recognise the contribution of all our staff in sort of healthcare, and we're quite committed to developing new roles and new ways of working. So we've introduced roles such as non-medical prescribers, responsible clinicians, and nurse consultants. So the assistant practitioner role seems like a logical step for us. Also, our nursing strategy is very committed to developing career pathways for both registered and non-registered staff within the trust. So this role is an ideal step forward for that purpose. Same as any other trust at the moment, we're facing huge challenges in redesign of services, and I see the assistant practitioner role as a key role in supporting other staff and other team members to carry out the roles that only they can carry out. So I see the assistant practitioners working alongside qualified nurses and medical teams to deliver high quality care. As I mentioned earlier, the assistant practitioners, are a key part to the team to enable others to do their roles and their functions, that they are trained specifically for. What I'm quite keen to do is develop the assistant practitioners into even more niche roles. So perhaps things like administration of medication, sort of monitoring medication side effects and medication education, I'd quite like to sort of send our assistant practitioners to our local universities to do level 3 study for perhaps talking therapies and other therapeutic interventions. And I think a key role for them in the future is to support the mentorship of new student nurses as they're coming through, perhaps in their first, even second years. I think it's a key role to developing your teams. I think that the more creative that you can be with the role, the better. Don't just sort of do what you've always done with support workers. Think of different ways that you can develop them to meet the changing needs of the workforce and the populations that we serve.
Reflecting on how far we've come really since 1998. As Carol said, I mean, we weren't the first in the country, but we were among the first in the country to do something quite large across the system. And I think the joy of doing it with Carol is that she's what I would call a demon for quality patient care. So there was never any question that this programme wasn't about patient care and high quality. It was never about saving money. I think that the context then was actually we had to make a really quite strong case for implementing assistant practitioners. There was a lot of hype from the RCN and a range of other bodies about how this was not doable at that stage. And I think it's been interesting, just reflecting on the path from between 1998 and here, the role of the assistant practitioners kind of was set up, and then it kind of contracted a bit until people got used to it, and now it's expanding again. I think the thing that's putting pressure on the assistant practitioner role now is some of the fallout from Francis about registered nursing numbers and the fact that assistant practitioners can't be counted as, you know, as part of the registrant population. That's obviously going to put the rest of the health and social care team under some pressure. So one of the, you know, that's the challenge that we face today, is to really make a case for why this role is so important in terms of the flexibility and high quality care it can deliver. I think the other messages that we've reached a place now where we have to have some standardisation, not in terms of roles because they have to be shaped around the patient, but in terms of training, in terms of organisational governance, and in terms of supervision, because it's about making a real case for how beneficial but also how safe and how we can regulate this role in the absence of any national regulation. So for me, that's the case to be made today. What have we got in Norfolk and Suffolk? A kind of a mixed bag. Assistant practitioners are hard to track because it's not coded on ESR. And also not all band 4s are assistant practitioners, and sadly not all assistant practitioners are band 4 because some people have done the training and are waiting for somebody to disappear before they can get the job, and that's quite clearly not okay. Not all assistant practitioners have assistant practitioner in the job title, and that's something we will be trying to work towards. And also not all assistant practitioners have foundation degree level training. So there's something about some standardisation here to make sure that as a group of people who may deliver very disparate services because they're patient focused, actually are part of a cadre with a standardised programme of training and standards and regulation in order to protect the role. What do we know about APs in Norfolk and Suffolk? Actually, all of the main providers have them, which is great. So, like a little virus spread out and taken over the world. The foundation degree and the competency portfolio has become the gold standard for underpinning education, and for me that needs to be the standard rather than the gold standard. What we did find is that in doing the competency portfolio, we don't have a very clear plan for mentorship for the band 1 to 4 workforce, and that's something that we're working on at the moment to make sure that there are other opportunities for assistant practitioners to mentor their colleagues and get the appropriate training and recognition for that. Assistant practitioner roles are found in a diverse range of settings. The value of the role, of course, is that it can take the underpinning competencies from across therapies, nursing and social care. It's valued and it benefits service users and teams. And certainly some of the videos that you'll see during the course of the day are actually quite uplifting, well, more than uplifting, in terms of assistant practitioners talking about how they benefit patient care. The assistant practitioner role is coveted as a rewarding role in its own right and also as a potential positive career step. What we're not looking for is every assistant practitioner to go all the way up, because we need a workforce that delivers essential patient-facing care, and we must never forget that that's what we are here for. So I'm going to sign off just to remind you of the conference aims today. We want to showcase to you the diverse range of assistant practitioner roles in Norfolk and Suffolk. If you haven't actually got assistant practitioner roles in your team, if you're thinking about it, we kind of want to give you some ideas and some networks to think about moving forward. We want to reinforce the value of the assistant practitioners to patients, service users and care teams in both health and social care. And we want to celebrate that. And as I said, we're using this as a platform to start talking about this more, both regionally and nationally. And we want to inspire you as individuals and also to thank you for all your hard work. We want to share best practice, we want to share knowledge, and we want to share some ideas. And we hope that you have a good day in the doing of that. We want you today to leave feeling inspired to develop the role of the assistant practitioner to improve patients' and service user care, but also to recognise the place of assistant practitioners in delivering health and social care in the future. I'm now going to hand over to Lorraine Barrett, who's the Head of Social Care in East Norfolk, who's going to talk about the role in practice. Thank you.
Right, morning everybody. So I'm Lorraine Barrett, so I'm Head of Social Care in the east part of Norfolk. I'm a qualified social worker. I qualified back in the 80s, and I've managed over the years a number of integrated teams across Norfolk and Suffolk. And I do feel very passionately about the role of assistant practitioner. I'm a real convert. I've been asked today to come and give an overview, to talk a little bit, give an overview of the health and social care agenda, both nationally and locally, to talk about the assistant practitioner role, particularly with a social care emphasis, but thinking about joint, and to talk a little bit about how I see the future of the role. Okay. Now, my business support person put these on onto the slides, and they're very whizzy-wazzy. They can come flying in from all angles, so it'll keep you awake anyway. So first of all, the context and the journey. There are three main themes, I think, that I wanted to highlight. And the first is integration. Integration is a leading issue, but what I was going to say is I realise that you'll have different levels of experience, so forgive me if I cover ground that you already know. But integration is absolutely a hot topic, and anybody that's been around for any time will know that we've been working in joint ways for years. But at the moment it's so much the hot topic, and it's a feeling of it's now or never really. There's various legislation that talks about integration, masses of it, but the main one I wanted to highlight was the Health and Social Care Bill. And in this it gives provisions about the shape of how health and social care should be shaped and governed. And also it puts obligations on all sectors to come together and work in an integrated way. And the other significant thing is that very, very recently, the collaboration of national providers and users of services came together with a joint statement about integrated care and support. And they described integration as patient-centred, coordinated care. And it's all been described as the most significant reform in the last 60 years. So it's really, really big, and there's a big change agenda. And just thinking about that in terms of integration and the key role from the assistant practitioner across there with the different roles. So the Norfolk picture, so having understood that we've got all the drivers, we have a Health and Wellbeing Board that has senior representation from all the organisations in Norfolk, and they have consciously used the word driving integration through. You know that we have in Norfolk 5 clinical commissioning groups and you will know that the idea is that these are GP-led and led by people that understand the needs of their own community and commission care accordingly. And we have various providers, I say that in inverted commas, but all the different organisations that you're from East Coast Health, NCHC, the Mental Health Foundation Trust, but importantly, social care has big elements of provision, and also the voluntary and independent sector are seen as absolutely equal partners in the agenda, and there are roles across all of those going forward for assistant practitioners. Okay, this is from Care and Reform, it's national guidance, and these are going to be sent out because I know it's a little bit blurry, but it just shows that they absolutely put service users and carers at the centre of all the development. Then you've got the commissioning, government, and then down here you've got everything that focuses on quality, regulation, ensuring that people are qualified to do the roles, and have the skills to undertake their roles. So the Norfolk picture. Over recent years there have been a number of key developments following on from the national agenda. About 3 years ago there was a big survey of Norfolk citizens, and they were asked how did they want their health and social care delivered, what did they want to see, and unsurprisingly they spoke about coordinated services, one person to know their story. They wanted a single assessment, and they wanted their care wrapped around the GPs. But the single assessment, the one person hearing their story, is a key indicator around the assistant practitioner role. And as a result of that, Norfolk became one of the national pilot sites for integrated care organisations, ICOs, and there were 6 of them across Norfolk. And they were really successful, and they had integrated teams of all professionals. And actually one of them that worked ended up, we had an integrated team, and the GPs were so enamoured of the assistant practitioner role that they now pay as an ongoing basis to have assistant practitioners based in their surgery. And those assistant practitioners can work across the team. We also are one of the first authorities to have truly integrated commissioning. So we have health and social care jointly funded posts who commission integrated care across Norfolk. There's been very recently a joint statement from all the key partners about a pledge to be working in an integrated way going forward and to have an integrated workforce. And we've also recently, the NHS asked for, the government asked for bids, pioneer bids around integration, and Norfolk have submitted 3. One in the west, one centrally, and one over in the east where I work. But regardless of what happens with those bids, and obviously we've got Norman Lamb absolutely peering over our shoulders, but whatever happens, those people have pledged that those integration, those bids, the ideas and the spirit of them will happen anyway. And the other thing I wanted to mention is the money. I mean, money's straightened, but there are 3.8 billion that's coming through, but that assumes integration across health and social care. The other second key theme, and this is prevalent in social care in particular, is about whatever language you want to use, but it's about being person-centred, having care wrapped around the person. It's personalisation, okay? And however you call it, certainly in social care, we had Caring for Our Future, which set out how this should happen. But it's very much, in social care, we have very stretching targets around individuals having a personal budget and being able to commission their own care. And if you think about the assistant practitioner role there, and somebody being able to gather that information and to work very closely with an individual to work out their support plan and help them to commission care in the way that they want it. And this, again, this is from Caring for Our Future, but it just shows, and it focuses very much on having a range of options about being able to give clear information and enabling people to make good choices, and being able to give that information and negotiate with somebody about their needs is a highly skilled role, and to be able to put people in control of their own destiny. So focusing a little bit more about the actual role of assistant practitioner. I wanted to say a little about the history, because actually assistant practitioners have been around in different guises for years and years. I mean, in social care in the 70s, they were family aides, they went right through. There are different titles. But another thing that I realised is the use of language. Across health and social care, we use different words for different, that mean the same or different things. We can trip over each other. And Kathy and I, even talking about preparing for today, realised that we were at cross purposes about the role of the assistant practitioner and what we both meant. And coming from health and social care, I think it's really important that we're really clear, exactly clear about what the role is in each particular setting and what we're expecting. The other thing I wanted to say, which Kathy referred to, is around the budget and the straitened times that we're in. And if you can have a skilled and flexible workforce, and if you can have workers who are efficient and effective, then this has to be the way forward. So speaking a little bit about social care in particular, that this is transferable. What we did, it was about 3 years ago, I led a roles and skills work stream. And what we did is we put up around the wall all the jobs that social workers, occupational therapists and the assistant grade staff at that time were doing, and we put them on the wall. And then we thought, okay, what has to be done by a social worker? What has to be done by an occupational therapist? And then there were masses and masses of roles and tasks that we need highly skilled staff to undertake. And so from that, we developed some very clear job descriptions around the assistant practitioner roles. And we've reviewed that as we've gone along, and those workers may work towards an occupational therapy and perhaps put in simple equipment, or they'll work to the social worker, or they will work in a generic way across both in the teams. We have assistant practitioners who attend multidisciplinary teams and represent all of the professions in the team, and so on. And we see the skill of the assistant practitioner role has been evolving over the years. But there are key ingredients to make that successful, and Kathy referred to a number of them in her discussion. And obviously we have to be really careful, and we don't always get this right, but about assistant practitioners not being taken advantage of, and that we're really clear about what the role is and where the boundaries are. And that's the way it can work. And we have Carla Hodgson, who specifically looks at the learning and development of assistant practitioners in the department. And we try to have a pathway, so any courses that are available for the qualified staff, assistant practitioners automatically enabled to attend. And where necessary, we sometimes have bespoke training if a particular need evolves. And we have been able to support some assistant practitioner staff to undertake the foundation degree. But I think this is something that we need to work on. And I think wherever we can collaborate on this would be really fantastic, so that we can absolutely develop a clear pathway. I guess the other thing that happens in social care, and I guess in other settings too, is osmosis, so that we have co-location of qualified and assistant practitioner staff. We have that golden thread of professionalism going through, and we see that that's a really key way of learning. But we do absolutely have structured supervision and support. It's key to the role. So assistant practitioners, as with all of our staff actually, have at least monthly supervision in a structured way, appraisals, but being able to consult, seek support when necessary. We learnt that it's really important to have very clear job descriptions and roles, but very, very importantly, we developed triggers so that assistant practitioners also know when to say no, when cases are handed over, and that has been a very important part of the way going forward. An assistant practitioner in social care, you heard James on the video clip there, but assistant practitioners are in all of our settings. They undertake very kind of different roles. So we have carers assessors who are specific funding, they're assistant practitioner staff, they focus on carers assessments, some working in GP surgeries in the East, working in different settings. We have assistant practitioners in the Norfolk and Norwich joint integrated discharge team. We have joint learning disability teams that have assistant practitioners right the way across. It's really, really exciting. Just thinking then, just to summarise, and thinking about the future. So with the agenda of integration and personalisation, with the agenda for being really efficient with resources, there's clearly a role for the assistant practitioner. It's about using efficient and effective use of resources, as I've said. We need to develop the really clear pathway and expectations, and I think we can absolutely do that jointly. And therefore, I think that gives us, a clear indicator, a very exciting future for the role. Thank you.
Well, thank you very much to both Kathy and Lorraine for a really informative session. It's really great to hear. Kathy is actually would like to ask the audience whether there are any questions for her from her session. Would anyone like to ask any questions? Just raise your hand. Aha!
Thank you. I would just like to know, you briefly mentioned about regulation of the assistant practitioner roles. Do you see them being regulated in the future?
Not in the very near future, no. And the reason is that it's actually quite hard for the regulatory bodies. If you think about the NMC, the Guild of Nursing and Midwifery, HPC, just AHPs, so actually the regulatory bodies are uni-professional. They're kind of, dare I say this, and not burn on the stage, but they're kind of the old world, really, aren't they? And the regulatory bodies have not yet got their heads around who could do it. And also, then they start having battles about, are you more of a nurse than an AHP or a social, this kind of thing. My view is that actually that's an argument that's happening nationally, and it's been an argument that's been happening nationally for some time. So if we hold our breath, we won't do anything. In all the evidence that we looked at, there's really good examples in other settings, but there's also, in Canada, I brought home a really good piece of work around organisational governance, codes of conduct. We could develop those kind of things. I don't know what we need, but I think we can do it together and let the national people argue among themselves and get on with it in due course, probably when we're all very old. Thank you. You don't have to just ask me questions, you can ask Lorraine questions. I just thought we've got some spare time, so let's use it.
Thank you very much. Anyone else? Any would like to raise a question? All quiet. Final call, any questions? Yes, those will be available electronically, yes, thank you. Well, thank you very much indeed, thank you. Thanks very much for your attention for those sessions. What we'd like to actually ask you to do, we can actually offer you to go to coffee. Coffees will actually be served in the marquee where you actually had your first coffee this morning. What I would actually ask people to do, if you do smoke, we would ask you not to smoke on the terrace just here, just beyond. That would be much appreciated. And we would ask you to be back promptly for the next session. We look forward to seeing you very soon. Enjoy your coffee. Thank you.